Well, good morning, everybody. Welcome to Samaritan's Poorest International Health Forum. I hope everybody is doing well today. Today we have Dr. Tom Wood speaking to us again, and we're privileged to have him here. This morning he is going to be talking about the program, the Child Survival Initiative. Many of you all that especially work in pediatrics are probably well familiar with this program, but we're just going to take a close look at how it impacts morbidity and mortality for children around the world. And Dr. Wood's going to also use this as an opportunity to discuss the Village Samaritan program that he initiated here at Samaritan's Poorest. So I think at this point I'll go ahead and just open us up in prayer, and then I will turn it over to Tom after that. So if you will, bow with me in prayer. Dear Heavenly Father, we just thank you for this beautiful morning. I believe it's the first day of spring, and God, we are thankful for the reminder of the birth of your Son and new life, salvation, and Lord, we just pray that you would just bless this program, just speak through Tom and use this, Lord, such that we may serve you better. In Christ's name we pray. Amen.
Good morning, everybody. Let's see, who have we got out there? We got Chad and Laura and Kristen, and then Pam. Hi, good morning, Pam. How are you?
Pam, can you hear us? Oh, there she is. Turn her mic up.
Okay. I just pray everybody out there can hear us. I'm going to go ahead and get us started this morning. When we're talking about the Child Survival Initiative, about a year ago, less than that now, probably 6 months ago, I went up to a conference in Washington, D.C. that was put on by our State Department. And what they were looking at is all of the work that has been done around the world towards the Millennium Development Goals that were laid out in 1990, and how far we've come in meeting those goals. And there's two of those goals, number 4 and number 5, the ones that we're particularly focused on and that this conference focused on. And that's the reason they call it the Child Survival Initiative. And that is to look at the work that's been done and the progress that has been made up until most of the data that they had was for 2010. So that's the data you'll see on my slide collection this morning. In reducing the child mortality rate around the world. And I'll get used to running this little machine here as the moderator. What this slide shows you is that starting in 1990, and since this was a Child Survival Initiative, mainly what we were looking at is the acronym, the synonym that they came up with it, the name was Every Child Deserves a Fifth Birthday. So we're looking at principally is the survival of children under 5 years old. And as all of us know who work out there in the field, those are the most vulnerable ages, for children. Once something happens, and your medical people would have to tell me about it, but something happens in the development of a child, when they hit around the 5 to 6 years old, where they become more resistant to a lot of the things that would kill them up to that age. So that's the reason we're focusing on that. And if you look back at 1990, you'll see that there were 12 million children died in that year of childhood illness, and that due to the work that all of us have done out there, and a lot of the rest of the people that are in international relief and international medicine, the things that they've done, that rate of number of deaths was lowered to 7.6 million by 2010, and it is now down around 7 million. But what that translates to is, we look at that and we say, hey, we've been successful, and the answer is yes, we have. But the answer is also the fact that at 7 million children dying, that's one child under 5 years old dies out there in the world every 4 seconds. So the thing I like to keep in mind to keep me motivated is that during the time that we are here talking in this conference this morning, several hundred children will die. The tragedy of that is, as most of us know, that they will die of very preventable, very treatable illnesses. It's just a matter of, what we'll show in the presentation this morning. A lot of it boils down to is a matter of access. The reason why they started this initiative is because they had laid out the Millennial Development Goals. Switch slides. They laid out the Millennial Development Goals in 1990, and with some very high aspirations for what they were going to be able to do, and we're not on target. We're in fact quite a ways off target in reaching those goals, and we'll get to that in just a minute. But I wanted to show you what our successes have been to encourage those of us who are working in the field, but to know that as the closer we get to the target, the harder achieving the target is going to be. So if you look at this chart that I've put up now, it shows, that there were 88 deaths per 1,000 lives in 1990 on children under 5, 73 by the year 2000. By 2010, it was down to 57, and that shows a 35% reduction if you do the math on that. In the death rate of children, those children. If you look over at the chart next to it, the one I just showed you, just in a different format next to it, it's 1990, there were 12 million children died, 9.6 in 2000, and 7.6 in 2010, and as I said, it's around 7 million a year now. So it's a very high rate, and it's something that the world has decided they want to pay attention to. The conference, the Child Survival Initiative Conference, was hosted in Washington, D.C. by our State Department, largely with to give direction to USAID and to encourage the interaction and they got probably, I would say, 90% of the nations from around the world attended and signed this agreement they signed the agreement that would lead to the initiative. And what they're looking for is reducing the number of childhood deaths by 2035 to 2 million, children a year, which is a really significant reduction. And I'm going to get into where the problem is at and what the focus should be as we go through this presentation. If we look at what's going on in the United States since 1990, and I want to acquaint you with this graph carefully because the way you look at it influences the way you will perceive what follows. And this is the United States. And if you look, what we need to pay attention to is the years will be the same on all the graphs that we look at. The scale on the left-hand side will change. So this shows, as an expanded scale so that we can see that the U.S. started out and, up in 1990 at around 30 deaths per 1,000 children per year. And by 2010, it come down to, it is now 7 deaths per 1,000 per year. So, we've had a good impact. It's not one we would like. There are countries that have better. And then that, most of them are in the Denmark and area of Sweden, where they're down to about 3.5 children per 1,000 live births, in their annual death rate. But I'm going to keep the United States on each one of these graphs as we go through so that you have a way of comparing, and then you'll look what happens with this one on the United States is the scale gets compressed and drops down to the bottom. But 80% of the deaths in children under 5 take place in Africa, particularly in sub-Saharan Africa and in Asia, and then a larger number, in Latin America and the Caribbean. So those are the areas where, the focus is. This shows you a look at Asia and what's gone on there. And like I said, pay attention to that left-hand scale, because if you see the USA is at the bottom there, the United States, so that you can see how we've compressed that left scale. And in doing that, so we can get all the scales on here together. And if we look at these countries, we can see all of them have made progress, significant progress, towards pushing towards the Millennial Development Goal. But none of them are there, including us. And and you can see that the progress that's been made, and some of the counts don't start until later. I'm going to point out here we've got Cambodia is that line, and it came down rapidly, leveled off, and then the rate of deceleration of reduction again picked up, headed all in the right direction. This one is, I have trouble reading my slide here because is Mongolia. And so, keep those in mind as we go through. But that shows you that the rate started out high, and we've been making good progress in reducing them.
Okay, Tom?
Yeah, go ahead.
Chad has a question. Does SIDS play a role in those numbers?
All counts of death, all causes of death are counted in those numbers. So SIDS, yes, definitely would be there. The largest number of U5s, and we can get into discussion later, but of U5 deaths, the largest percentage occurs within of the first 6 months of life. So that's there's a very high death rate there, and that's why lately a lot of the push internationally has been on maternal child health, because a woman dies in the process of delivery or shortly postpartum every minute and a half in the world, and a child every 4 seconds. So there is a linkage there with that lower rate. This is West Africa, and as you can see, again, the scale is compressed again on the left-hand side, which to bring get those scales all in, and you can look at these countries. I'm sorry about the size, but this, I have copied these and put them in there, but you can see how each one of the countries is making progress. Sometimes the progress levels off, and that's usually indicative of civil strife that takes place in the country, and we've had in those areas of the world a lot of civil strife over this time period. So the focus goes away from saving children's lives to, fighting each other over territory or money or whatever it is that people, they end up fighting over. Okay. This one is Southern Africa, and again, all in the right direction, all of them still high, and I would like to be able to read these better than I can. But
what's the one that gets up and then down?
This one down here?
The green one? The one just above the U.S.
That one?
Yeah.
Okay. Can you read that?
That is... Boy, I can't...
Sorry, I apologize for the small size, because this even reduces it more because we only get part of the screen on this display. Yeah.
Is it South African?
South African. Yeah, it is South African. Yeah. And as you can see, the upturn there is probably right around our apartheid. At the end of our apartheid is when it went up, and then it's headed back down again. So, like I said, the civil strife plays a large role in these, in our tracking towards the Millennial Development Goals. This one's Northeastern Africa, and Kenya, and Uganda, I think. Is that right? Yeah, out of there. And you can see that there was a big upswing, in Sudan. Sudan. There was a big upswing in Sudan. We all know what that was about. I would imagine that the statistics are not broken out for South Sudan, but I would imagine that over the next time period when we break out South Sudan, I know that we're going to see a very high rate. And that's because of the mass migration of relocation, repatriation of some people, and resettlement, but then the large immigration, the refugees coming out of the war-torn areas around the border between those two states. The next slide shows the Middle East. They have made, good progress. It continues. It's going to be interesting to watch this, not from the standpoint of interest, to see what it does to the death rate, but the current Arab Spring has significantly disrupted health care in those areas, and particularly what's going on now in Syria. So we will keep an eye on that, but the influence is still there, that there is a downward trend. And we need to look at that as far as I'm an epidemiologist, and so, I look at these trends and say, okay, where are we going and what are we trying to achieve and how are we going to get there? This is Latin America and the Caribbean, and all of those are going down. The very interesting one to look at is the top one on that, and that sudden up spike, and that was the earthquake. And then the cholera epidemic in Haiti that caused that. But all the rest of them, the trend is definitely in the right direction. This is a composite that shows you a lot of things. The green line, on the furthest left, is what the current progress has been. It shows you it's a graph of those first data that I showed you, down to the point where in 2010 it said there's 7.6 million deaths per 1,000 live births, and then it shows you the curve that would have to be achieved, the green, in order to reach the Millennium Development Goal 4, and that's the reduction of under 5 child deaths. By the year that comes to maturity, and that's in 2015. And that's an unachievable goal. And that's the reason why the Child Survival Initiative happened. And so they went in, they said, okay, we need to reset that goal to something that is achievable to keep people motivated and to encourage the financing of the efforts in child survival. So what they come up with is the Child Survival Initiative, and that is the blue line. And the blue line shows that by 2035, the projection of getting under 5 child deaths down to 20 per 1,000 live births per year. And the red line shows you the projection of the current rate of descent. And the curve, the fact that it's a curve, the thing that I look at as an epidemiologist is this. The black line is mine. And the reason why, given what I know is in a curve like that, is the closer that we get to, to trying to reduce those deaths, the harder it gets to overcome the causes, and there are many causes for that. One is many of the organisms for which we've developed antibiotics are developing resistance. The biggest one, though, that will come out of some of what I'm going to show you is the fact of access. We're getting access and increase in quality of medical care in a lot of the cities, around the world, and associated with places like the missions hospitals like Tenwek and Kajabi in Kenya, and so we're improving that. But at the same time we're doing that, the children that are left in that curve, one every 4 seconds, those children, they're in remote areas, largely in remote areas, hard to reach areas, or they're being affected in epidemics or warfare, or they are being infected by the fact that the organisms in which we're trying to affect are becoming more resistant. Any questions about that? I wanted to put this figure up there, and what I want to focus on here is that those numbers in the middle there. And, it shows you that there's 265,000 mothers die of complications of pregnancy and childbirth, and this was in 2010, and telling us that we're not going to reach Millennium Development Goal 5 either. There's 1,243,000 babies die before they reach 1 month of age. 3,157,000 children who survive the first month of life die before their 5th birthday. And when we think about those, we have a tendency to say, oh my gosh, I cannot affect those large numbers. And I think we need to keep in mind that we're not expected to. We're expected to affect what we can. So as each one of us and each organization that's out there working saves one life, then we will be able to reach that, the goals that we have, and that's reducing childhood death down to that 20 per thousand by 2035. And we need to keep that target in mind and keep in mind the fact that it is a large number, 7 million. But if you break it down to if it's your child that's sick, what you will do and what you will go through, in order to get that child to care and make sure that the proper care is given to the child, is something that we need to focus on and make available to all the children in the world. This slide tells you that the child survival gap between the richest and poorest countries is due largely to a handful of infections. Most notably, the 2 largest killers are pneumonia and diarrhea, both of which now we've got a pneumococcus vaccine. That's very effective. There are other causes of pneumonia than pneumococcus, but that's one that if we can get the vaccine out there and get it available, it will have a large impact. And then we have the growing wealth of knowledge about how to manage childhood diarrhea. And largely the contribution to that has been low osmolar ORS, oral rehydration solution, and then antibiotics that can be effective. Yeah, Lance?
And Tom, just to add to that comment about vaccines, if you look at the vaccination profile available now, or potentially available, the 2 big bacterial killers are Haemophilus influenza type B, so we have HIV available, as you mentioned, pneumococcus for strep pneumoniae, and then of course we have MMR, to cover measles, which is a big makes a big a contribution to mortality with pneumonia, and then we have diphtheria too. Not to mention actually influenza too, which is now they're recognizing is they used not to attribute a lot of influenza infections to children, but it's certainly they're recognizing that it is in fact. But my point is there's a wide array of vaccinations available, and if we can utilize and implement those, it'll have profound impact on reducing mortality associated with pneumonia.
Yeah. Okay. Good. All right. And then, like I say, in diarrhea, the newest thing with diarrhea is the low osmolar ORS, and then you now add to that the addition of zinc, and the fact that zinc reduces both the duration and the intensity of diarrhea associated with many of these illnesses. So we're making progress, but the progress is slow, but we have to be deliberate. This is just a chart that breaks down the distribution of deaths and under 5 worldwide in children, and as you can see on there, the 2 largest bodies on there are pneumonia and diarrhea. The next largest one on there is preterm birth, and the others is just a category where we can't classify this 18%. It's just a number of things altogether. Couldn't break it down, but you can see that measles has been reduced down to 1%. There's a very effective, very intense national measles immunization program going on. It used to be, when we talked about the five top killers of children, it was measles, malaria, malnutrition, pneumonia, and diarrhea. And so now that we're focusing down on the 2 biggest ones, and with the fact that measles isn't completely defeated, but the vaccine is very effective. And in fact, if we go into a disaster situation and start dealing with the medical needs of the community, one of the first things we look at is the measles immunization rate. You have to get up to 90%, 90% to get herd immunity, and that's our target when we go in. Currently, Samaritan's First does not have cold chain capability, but it's something that we will be working on pretty diligently in the very near future, because as even with the pneumonial vaccines and the other vaccines that became coming available, we need that technology and the ability to deliver vaccines to the field and keep them effective, for us to become more effective at what we do. YIDA, for example, is the refugee camp in South Sudan. When we went in there, we were the only NGO there. UNICEF came in support of what we were doing. But when it came down to measles vaccination of the group coming in there, and they definitely did not have the 90% level that they needed, we had to have another NGO come in. The first group that came in did not have the complete cold chain capability, and so their immunization largely failed. But then another campaign was organized, and the second one was effective. The thing about a camp like YIDA is that once you've got the herd immunity up to what it needs to be, the kids immunized at the rate that you need them immunized, then you've got to keep that up. Because the camp when I was in YIDA was right at 20,000, and it's at 65,000 today. So and growing. So we have to. It's a continual focus. This shows you the distribution of where most of those deaths occur, and as you can see, the largest portion of them are in sub-Saharan Africa, a very large portion also in Southeast Asia, and then you have the rest of the world up there in the little gray box. So, the fact is that Samaritan's First, our largest outreach is into the sub-Saharan African area, and then we also have an outreach in Cambodia and Vietnam. We're doing what we can in the way of feeding programs, safe water programs, and health and hygiene work, but there's a lot more that needs to be done. And a lot of these deaths we will only reach once we get the ability to deliver good medical care to remote areas. Prevention is important, as everybody sitting here at the table knows. It's the most important, but without care, without the medical care aspect, you will never be 100% successful. Okay. This breaks down the numbers in the countries, and the red arrows show you, where SP has offices. And, you can see 25% of the deaths of these U5 children worldwide take place in 6 of the countries where we have a presence. So we have the ability, we have the presence, and, and we can reach these kids once we develop the in-house ability to do it. We're helping the kids, and we're with all the programs that we have, but there's a lot more that we can do and should do. And this just, this is a quote out of, need my glasses. It says pneumonia and diarrhea, that's the major killers of children. It's a quote out of that. It says, indeed, the world has made substantial gains in child survival over the past 2 decades, although progress has been uneven and inequitable. And that's what I want to focus on right there. The highest child mortality rates are in the world's poorest region and in countries, and within most countries, the poorest and most vulnerable children are the most likely to die before the 5th grade. And that's got to be our focus. We've got to go to focus on getting to those kids that otherwise can't get to care. This one is the poorest and most deprived children often have the highest risk of infection and severe disease and are the least likely to receive treatment. Extending the health system into these hard-to-reach and underserved communities is essential to reducing childhood deaths, particularly those, due to diarrhea and pneumonia. These are not my words. This is extracted out of this article. The evidence indicates that trained and supervised community health workers can provide high-quality care that substantially, improves child health outcomes. And that's where the direction is headed in the world right now, and we'll focus a little bit more on that in a minute. Community health workers should deliver integrated treatment services for common childhood illnesses such as pneumonia, diarrhea, and malaria. And many of the countries that have been on that map, the ones I showed you with the red arrows, many of those countries do have currently what they call integrated community case management services that the government has put up and is trying to run. Those are being principally are targeted at maybe one or two diseases at the most, and most of them are targeted at malaria, and they're being very successful.
Are those all under the auspices of this this program that we're talking about?
No.
Okay.
No. The fact that the reason I mention that is that we have a program, and I'll talk a little bit more about it in the end, called the Village Samaritan program that we're still in the process of finalizing. We have it in place in Honduras and 6 communities, and that program takes villagers and trains them through a 6-week training program, places them back in their village, and then they're equipped and trained and supported through a nurse manager to provide health care services for their village, not just for the under 5 children, but for health care services for those 5 killers. Okay. And then the program experience shows that an integrated strategy can manage treatment coverage and improve quality care for sick children. So the program that we're talking about is, we're not the inventor of it. We're not the idea of it. We have just taken it and put a spiritual aspect with it. We have our program, our training program is much more intense. The training programs that are in place in most of the countries right now are short. Some of them as short as 2 days. Many of them in a 1-week time period, but they're focusing on care for one disease. So getting mosquito nets out, and then rapid diagnostic test for malaria, and then malaria treatment medications is like one focus that they have. Okay. Paraphrasing that one, it says, by increasing key interventions throughout the country to a level of the richest 20% of the households, we could reduce the number of children dying from pneumonia by 30%, and the number of those dying from, the outcome of diarrhea by 60%, which are just huge impacts. So if we can get care to them, we can save their lives. This slide shows you that countries have, in the developing world, have programs and policies that they put in place. They recognize and understand the need to get care out to their more remote areas. But in doing that, they have good ideas. They just don't have the wherewithal in terms of money and financing to support it. So they have the policies, but if you get over to that right-hand column, that's where the rubber meets the road. That's the application of actually what's going on out there. So, for diarrhea, for example, 16% of the people in these communities, are under case management for diarrhea, and 9% for pneumonia. So, there's a lot of room for improvement just between having a policy and putting it in place. And we have all worked in those countries, and we know the challenges they have. For instance, and I'll go back to Honduras. Yes, there's a healthcare system. The Minister of Health has done a very good job of putting together policies, and then getting rural hospitals developed, and then from that getting rural health centers as outreaches beyond that. But for example, the 6 villages that we're dealing in down in Honduras have, each one of them was selected because it's greater than 3 hours by any means of transportation from the village to the healthcare center, much less the hospital. Once they arrive at the healthcare center, there are long lines, and if they take the 3 hours to get there, they will set 3+ hours, waiting to be seen. And then if they are seen, there's a very strong likelihood that the medication cabinet is empty. Either that, what they end up doing is they give this family that has struggled to get in a prescription for them to take to one of the local pharmacies, and there are numerous pharmacies, but the family simply cannot afford the medication.
I'll tell you, when you hear these stories about the access to health care in third world countries, or I should say the limit to health care access, I've had a practice for 15 years here, internal medicine practice. It just gives you an appreciation of what we have here. I know nobody likes to wait, but we get upset sometimes when we wait for 30 minutes or an hour for a physician. Next time you're in the doctor's office waiting, think about that.
It took about 3 hours to get there,
and then another 3 hours to wait, and then there may not be the pharmaceuticals to help you after all that. So anyway, we're pretty privileged.
Yeah. Okay. This graph shows you, again, a look at across the developing countries, fewer than, a third of the children with suspected pneumonia receive antibiotics. And if you look over on the right-hand side, there's a comparison in the countries that are highlighted there in the areas, South Asia, Sub-Saharan Africa, and the Middle East. The comparison is between urban kids and their ability to access medicines versus the rural kids. Now, you can see even the access for the urban children is limited, but the access for the other children is even much more limited. There's only one country in the world, and that'll come up in a minute, where that's flipped. You can see here, actually, there's 4 countries. But again, it shows the discrepancy between care available to urban children versus care available to rural children. And although it's limited in all of those countries, it's much more limited for the rural children. And then the 4 countries over here, those countries, it's actually reversed. And it'd be interesting to go in and study those countries and see what the circumstances are that they're able to reach the rural children, better than they're able to reach the other. There's very little statistical difference in those first 3, but you can see Uganda.
I can't imagine that the urban would be better reached.
When I look at a graph like this, and we all know, I'm sitting at a table with people who know. Okay, we all know statistics lie, and liars use statistics, okay? And I'm not saying any of these governments lie, but people will paint pictures to make themselves or the country look better. And so we know, we've been out there and we've seen it at work, and I'm not saying that any of these countries do that. I'm not going to accuse anybody. I think that one is, the thing that we look at is that the fact is we are having an impact. We need to keep persisting in having that impact. And the fact is that when it says in the just like for the cholera outbreak in Haiti, that 8,000 people died, we know that's not true. We know that it's probably half to 3/4 more than that 8,000. It's probably 16,000 to 20,000 people.
Yes.
Yeah, easily. Mm-hmm. So, the fact is, keep in mind these statistics come from the countries by their ministers of health. And, and so that's what you're looking at.
Is that access to ORS in that particular case?
Actually given ORS.
Actually given.
Yeah.
The only thing I can think for Uganda is the NGO presence.
Exactly.
In the remote areas,
in
the rural areas, rather than, and they may well be performing better than Ministry of Health clinics in the urban areas.
Right.
They may be giving out free ORS, whereas in the urban towns you may have to purchase it. I mean, there may be some differences like that. Yeah.
I thought it was interesting that it does show that. So something's having an impact, and Jody, that's good insight. Is that it could be just the very presence of the NGOs providing that makes that difference.
And in the urban areas, at least I've noticed there's a lot of these tiny little clinics / pharmacy type places.
Right.
And the treatment, people go there for treatment, but it's really horrible. Whereas I think a lot of times in the rural areas, there may only just be the clinic.
Mm-hmm.
Yeah. And so it may, that may be some of the discrepancy. I'm not I don't know. I'm just speculating here, but.
Anyway.
Lisa, you had a question?
Yeah, I was just going to say that in some of the countries there, the urban slum could be playing a large part in that as well, where people are, in very poor living conditions and probably worse off than they would be in the rural areas.
Yeah, very, very true, probably. Lisa, what I'm thinking of as you said that was our experience with Alive and Thrive, in Honduras.
Right. I don't know how to do the chat, so can I also make a comment about the previous comment about SIDS? And that would be that
go ahead.
That SIDS is included in these numbers, but SIDS in relative proportion is such a tiny problem compared to the other diseases we're looking at in developing countries that it's really not much of an issue in terms of the big picture, except in Western countries.
That's true, yes.
All right, good. Did we get your question answered, Lisa?
Yes, I did. Thank you.
Okay. I'm hammering this point for a purpose, and that is within most countries, the poorest and most vulnerable children are the most likely to die before their 5th birthday. And, I think for those of us on this conference today, that is just more than obvious. What we need to focus on are equity-based approaches, focusing on expanding services and reducing disparities of these essential services and out-of-pocket expenditures for the poor. And with that, we have the possibility of a 50% reduction in the under 5 mortality rate. Now, I don't know where they developed that figure from, but the fact is that if we can do that, and Bill Gates and the Gates Foundation has made large strides in getting pharmaceutical companies. In fact, the 5 world's biggest pharmaceutical companies now have joined in this battle and agreed that for developing nations, and I don't know how they're going to define that they will provide all medications at cost. Gates is having a large influence when it comes to getting both governments and industry, and particularly the big pharma industry, involved in combating this problem. But we need some way of getting it out there. Okay. The next thing that we need to look at is community-based delivery platforms, providing packages of essential health services. Talking about integrated community case management here, and minimizing barriers to use, like eliminating users' fees and reducing, transport costs. We can't do that completely. Nobody can do that completely. But in Honduras, we took a $15,000 ambulance that we got from a program that closed down in Mexico, and we dedicated it to this program. We equipped the medicine cabinets in the 6 villages that we're operating in at the cost of 13 cents per person per year. If you figure the entire village, presence, and then we have a nurse supervisor who is now participating very heavily in continuing education for these village Samaritans. And, the program is being very largely successful. The latest thing that they have done is they wrote, and they've asked for, and didn't need to ask for, they just need to tell us. They are now taking all of the ladies that show up as pregnant, and they're going on prenatal vitamins, and they're being transported with the ambulance into their prenatal visits. And now the latest one that they're going to be doing is that they've asked and told us this time, not asked, that they're going to be offering pap smears in the villages. So, there's a large outreach to the villages. The villages themselves, the health committees are becoming increasingly involved, in the care and the maintenance of their system. The villages recognize that the program needs to be sustainable. They also recognize that we are an NGO and that we will not be there forever. And so they have established, the health committees have established a village fee for, some of them charge 50 cents per visit, from the village Samaritans. Others charge a village tax of $1 per person per month. But they're building up their own treasury, so that they can support the medicines that will be needed, to sustain the service. The only thing that will need to be added to that, and depending on where we are able to get with negotiations with the Honduran government, is the continuing maintenance of the ambulance and the continuing supply of the village Samaritan nurse manager. So that her salary and the cost of the ambulance are our largest expenditures. Okay. If you look at this slide, it says, in Africa, excluding North Africa, diarrhea, malaria, and pneumonia are responsible for more than half the deaths of children under 5, and malnutrition is an underlying cause of a third of these. Children from rural and poorest households are still at a disadvantage, and many of the poorest are marginalized, and most marginalized children, especially in hard-to-reach areas, have been left behind. What we did in coming up with the idea behind the Village Samaritan program is we took the very advanced stages of integrated community case management. We integrated that with the idea behind the Community Integrated Management of Childhood Illness, IMCI. And we put a spiritual program, platform with that. And we developed what was called the Village Samaritan program. As I was saying, our training program for the Village Samaritan is extensive. We are manualizing that training program. That manual is, I keep saying it's, trying to project when it will be on. We've got Lindsay Plummer as our curriculum writer, and we should have that manual finalized by the middle of next month. Then it will be available for anybody who wants to take it. It is an extensive training manual, for the basic health care needs for a village Samaritan to provide in their particular village. It also has we built into it based on some learning experiences we had, particularly with a survey group. We had to go down and talk to the village Samaritans. We built into it some scenarios so they can actually be taught what the expectations of people who assume their roles are. Currently, the major holdup on the Village Samaritan program is it needs to become self-sustainable. We're looking at a target time of 3 years in order. We'll support it for 3 years, and then at the end of 3 years, it needs to become self-sustaining. And and then the fact is that the maintenance of that ambulance becomes really important. Okay. That's about the end of the program, the presentation, and I'm open. We're open to any questions you might have.
Tom, what is, in your experience, since you initiated the Village Samaritan program, I'm sure it's not easy to launch and maintain. And what are some big obstacles that you've encountered to try and maintain this program?
The fact is that we have to do, being an NGO, we won't be there forever, so we have to make a program that is sustainable beyond 3 years. Mm-hmm. So that's a large one that we are looking at. We're very pleased with the progress we've seen in Honduras and the fact that the villages are taking ownership of the program.
Good.
Brad Phillips down there has been very adamant from the very beginning on talking with the villages that they understand it's not our program, mm-hmm. It's their program.
Right.
And we're there to help them get it up, to launch it, and and to set it up to where it can be sustained. Mm-hmm. It's up to them to come up with a wherewithal to make that happen.
Right.
So, that's one of the obstacles. We have run into very few obstacles other than that, because the villages, the healthcare system of Honduras, the Ministry of Health of all, when they see the program in operation, been very solidly behind it. In fact, our strongest supporters are the doctors that are assigned to both the local hospital and to the village healthcare centers. Those are some of the strongest supporters of the program. And then, okay.
No, so yeah, as a physician, I would imagine if I was in that setting, I'd be probably pretty supportive of a community outreach program like that, because they're really they serve as physician extenders, if you will, and I think they take on a lot of medical issues that otherwise would land in the lap of the physician. So I think it could potentially diminish his responsibility and workload, and so it's a nice complement to a physician's health care, provision of health care.
Then the latest thing that I've adopted an interest in is what they call, used to be called e-medicine, electronic medicine. Now they're calling it mHealth, which is mobile phone technology and associated with the delivery of health care in remote areas. And if we look at the explosion of mobile phones in remote and in developing areas around the world, it's something that we all who are interested in the field of international health should be aware of. Is tracking, how these phones are getting out there, and they're getting into a lot of hands. I've heard that the cell phone availability in Nairobi, for example, is 80%. And it's reaching into several areas. Each one of our village Samaritans in Honduras has a cell phone. One thing that we discovered was a problem with the cell phone technology in remote areas is charging the batteries. So I'm talking to various, power delivery groups around, from this form of electric power. What we ended up with in Honduras is we killed two birds with one stone. There's a large degree of asthmatic conditions associated with life in those villages from the amount of smoke they breathe in the household and other reasons. So we equipped them with a small generator to run a nebulizer. So that they go in and the doctor prescribes for them at the health center that they need these nebulizer treatments. They now can go to the village Samaritan, and we have a nebulizer and a generator to run it. The little generators, the only thing you have to worry about with them is okay, how long will they last? They're $98 for the generator. And how do you get gasoline for them? But the thing is it's become a livelihood thing for the village Samaritans, and a livelihood thing for the village Samaritan in that they can charge cell phones for the rest of the villagers and charge a fee for it. So that way they can earn the money to buy the gas. Okay.
Lisa?
There is a wonderful company called Tough Stuff, which I saw at a trade show. They have, it's the size of a notebook, and it's a small solar panel which people can use to generate electricity, from the sun, and use it to charge their cell phones. And this can be an income-generating activity. The panels, I think, cost about $20 or $30. And when somebody in the village buys one, they can have this little industry charging their neighbors' cell phones. So that might be something to look into for this program.
Yeah, Lisa, you're right with me, because that's another area we're certainly looking at. At the mHealth conference in Washington recently, I told every vendor there, if you can come up with a cell phone that I can set down in the sun and it will recharge itself, you're going to sell, you've got a fortune on your hands. So that's what I'm looking for. I'm looking for that way, and solar power is certainly a way. And you're right. If they have a solar panel that can, charge their cell phone, they can also use it to charge a battery, and that battery then can charge even during the nighttime, recharge cell phones, and they can certainly use it for livelihoods. So.
Right, I think this was a battery system. It was also being used to charge lighting for people, little LED lights for people's houses, which was, environmentally and health friendly because they weren't using kerosene lamps anymore.
All right.
And I've seen a very similar model, Lisa, that's been done promoted as a small business that has a very similar LED lamp with cell phone charger, all on a small solar panel. Very affordable. They were like $20, I think, in Uganda that you could get them for.
Yeah. And many of the cell phone companies around the world, one is they're looking for efficient technology like that, but the other thing is they're looking to increase their market. And so much so that they are largely giving cell phones away, and, in order to sell the service. And so I think we can look forward to the fact that communication with these remote areas is going to do nothing but improve and improve very rapidly. And as we get that communication, then we should be able to take advantage of it to bring health care into those areas. The one thing that I wanted to remind people of before, and I'll close because it's time, is that with mHealth, we're talking about dealing with people in remote areas. One is you need a trained person there to do that. The Village Samaritan or other type ICCM programs are a way to do that, and we should promote and encourage those. The other is that with the mHealth technology, we have to remember that we cannot send one-way messaging and expect it to have any effect. I think that we learned a very large lesson in Honduras in the Alive and Thrive program. One-way messaging, and it's been shown now in many, many subsequent studies by other people, does not work. A lot of people are not going to turn their phone on to download a message from somebody they don't know. And so we have to keep in mind that mHealth shouldn't be for messaging, it should be for communication. So if a person comes on and asks a question, then they're going to be looking for an answer, and you've set up a dialogue, and now you've gotten them in a place where we can now teach them. If it's the other way around where we're just sending messages up to them, there's no dialogue and there's no interest they have in participation. So remember that as we develop mHealth, we'll set it up as a form of communication and not of messaging.